All right, hi everyone. Thank you for joining today. This is Lindsay Weeks, and thank you for joining the HIMSS series for 2022. Today our speaker will be TJ Youngquist, the Assistant Deputy Director for Policy Planning and Operational Support. HIMSS is a global advisor and thought leader supporting the transformation of the health ecosystem through information and technology. And this is Lindsay Weeks. I am the Michigan HIMSS Program Chair, and along with me are Megan Vanderstel and Sharon Kim. And some of our sponsors are on the screen. We would not be able to have these webinars without our sponsors, so we always want to make sure we give credit where credit is due. So thank you to our premier and executive sponsors. Now, today during this presentation, if you have any questions, please feel free to put them in the chat. Once we get towards the end of the presentation, we will ask if you want to verbally ask a question that you raise your hand. And once we get through those raised hands, then we'll just go ahead and ask if anyone wants to come off mute and ask any questions. Today, our presenter is TJ Youngquist, like I said, and I'm going to go ahead and hand it off to TJ.
Thanks, Lindsay. Can you hear me?
I can, thank you.
Awesome. Well, thank you all for sparing your lunch hour. Like Lindsay said, I'm TJ. I use the pronouns he and his. I'm the Assistant Deputy Director for Policy Planning and Operational Support here at the Michigan Department of Health and Human Services. First I'd like to acknowledge that this effort would not be possible without the partners that we have at HIMSS, on the Michigan Health Information Technology Commission. The topic that I'm going to talk about today, which is the updated health IT roadmap for Michigan, really has been a hugely collaborative effort. I'm going to briefly turn my camera on here just so that you all can relate the voice to a face. I know that cameras can sometimes eat up bandwidth, but I'm really happy that all of you could join to talk about the now adopted, updated Michigan Health IT roadmap called the Bridge to Better Health Report. The commission adopted that at last month's regular commission meeting. As a lot of you know, the last Health IT roadmap was published over a decade ago, so this effort really has been kind of a long time coming. And of course, there's a lot of work to do to kind of catch up over the fact that we've not had an updated roadmap since 2006, I believe. So I'm going to turn my camera off now, switch over to a slide deck. I do know that, a lot of folks have seen, Lindsay, are you seeing the title slide?
I am.
Okay, perfect. Yeah, so I know that a lot of you have seen a version of this presentation either through a commission of event or at the actual commission meeting. So I want to give a little bit of a different twist today and still present the general overview about how we got to adopting this report, but also go through the report a little bit and give a sense for what's actually in the adopted report, what some of the elements are referring to, in ways that we would like to partner more broadly, continue partnering with stakeholders that have helped us get to this point of adopting a roadmap, but also thinking about how we can implement it. So I'm going to go over some history that led us to the point of adopting this new health IT roadmap. We are going to be taking questions at the end, but feel free to put any that come to mind in the chat. And if there's any that are really kind of eye-catching, Lindsay or Lee, feel free to interrupt me and we can take the question then. This is really meant to be a collaborative time to kind of go over more in depth the roadmap. So I want to kind of invite collaboration as we're going. And when I get to talking about the strategic initiatives, I'm going to switch over to the PDF of the adopted roadmap just so we can take a little bit of a deeper dive. So I know that a lot of us are familiar with kind of the progression of health information exchange over time. And there's been some visioning both through federal regulations and just kind of general trends within the health IT field that kind of give us some feel for how health information exchange and eventually community information exchange will continue and be operating into the future. So, you know, we all know the concept of regional HIEs that were really paramount to the original Conduit to Care report. You know, while regional efforts really do contribute to connecting not only providers in an area, but also support services like payers, labs, pharmacies, those regional efforts, you know, of course, led us to, well, a lot of duplication of effort in the past, waste and expense. And it's fascinating because I do want to bring up the point that we're almost seeing the same process repeat itself as we're watching community information exchange emerge. We're seeing a lot of regional efforts. You know, for example, the Shire efforts during the state innovation model, where we see regional connection points for providers through, you know, integrative technology like referral platforms, care management platforms. So it's interesting to note that CIEs are really kind of on the same trajectory as HIEs kind of were over a decade ago. Something to consider as we're moving forward with how we develop a CIE infrastructure, just noting that there's a lot of parallels with how HIE had developed. And now the network that we all know, which is the Michigan Health Information Network, really helped to facilitate that network of networks infrastructure, which has really served the state well to have that single point of connection to external clinical and kind of support service partners, really leveraging the regional HIE model, and also having inroads to federal efforts, EHR-led efforts, payer efforts. You know, we all know that federal regulations are really kind of looking at kind of the interstate highway of sorts, with HIE kind of going national. So looking at how, you know, our state's health information network, how that will eventually connect up to a QHIN's connecting regions of the country together. So that way there's more fluidity with, you know, folks that are transient, folks that may kind of live in different parts of the country, that their health information can really, you know, go wherever they go. So that's, of course, one facet to think about in terms of future state for health information exchange, just this whole federal model based on TEFCA. But of course, there's a whole lot of other things to think about, especially what's going on with social care data sharing. Pushing the wrong button. Here we go. So a little bit more about health information exchange in Michigan. As we're all aware, you know, there's been a lot of strengths that have led to a really dynamic health information exchange infrastructure, especially with the merging of Great Lakes Health Connect and MyHIN, bringing together longitudinal web-based patient portals to make, you know, historical information more interoperable across systems on web-based platforms. Referral platforms, which increasingly are becoming more important to how we think about addressing social determinants of health. We know that Michigan was a leader with ADTs, and the future of how alert routing will look is something that we really have foundationally established in this state. And then, you know, the kind of bread and butter of the ACRES platform, which gives us the attribution and the kind of legal route to share information. So a lot of great ingredients that make and give Michigan a really good foundation compared to a lot of other states that are still kind of figuring out a lot of these kind of core things that have to be present in solid HIE models. So some high-level strategy for where the Bridge to Better Health report emerged from. So we know that there were some core tenets within the Conduits of Care report that really spoke to the time of kind of building out EHRs, interoperability between those systems, having a information network across regions and across the state, So of course, there's elements of that that carry into today. There's still the focus on Michigan residents. I mean, ultimately, any technology that we build has a people purpose. It has to serve the needs of care coordination and care management for Michigan residents. So that's, of course, very foundational still to this current roadmap. The state has invested, well, state and partners have invested a lot of money into building up HIE, and it really has been a public-private effort. You know, we wouldn't be where we're at today if we didn't have the incentive models like through PGIP. We wouldn't have the network that we have today without our partnership with the federal government to be able to really invest in a lot of these core use cases. So really making sure that we're making the best use of those existing investments and not reinventing the wheel. And collaborating across sectors is something that, again, we've seen be really successful with building out this updated roadmap. And it will be something that's going to be continued to be very crucial as we implement the updated health IT roadmap. I did want to dive a little bit deeper into the focus on Michigan residents because we do know that talk about health IT can be very complex. Talking about care management systems can be very complex, and how those systems do and do not interact. I mean, at the end of the day, we're serving residents. We're trying to make it easier for folks to get care, give them better care, give them more quality care with less errors at the time that they need it. So what do we think an updated health IT roadmap will mean for residents? You know, really speaking to the need for streamlining services, cutting down on the kind of platforms that folks have to interact with, making their experience with the clinical infrastructure more streamlined, improving connections between systems. We've really seen this be crucial, especially during the pandemic. You know, in an expedited fashion, we had to build up pretty complex systems to make sure that folks are able to stay connected to their providers, get access to necessary services like testing and vaccination. So, you know, health IT has enabled a lot of those capabilities. And also, as you know, folks are using more apps and wanting to access their information in a more coordinated fashion, figuring out ways that we can make that easier for residents, because ultimately when folks have access to their health data and they're able to manage the consent of what they want folks to be seeing of their data, ultimately you're empowering people to be able to manage their health in a more confident fashion and, you know, really take control of the care that they receive. Kind of one more slide that I think I've really already kind of touched on, but really driving home that the continuity between what was published in 2006 with the Conduit to Care report, we really wanted to be conscious to carry any of those same elements forward that we can. So we know that digital connectivity to data is something that has emerged a lot. Access to broadband is something that is a huge barrier. You know, folks can't even access health IT without that basic access to getting on the internet. So of course, that's a major barrier that we touched on. Taking that collaborative approach to finding out what do stakeholders actually want health IT to be doing. You know, we can talk about services and use cases all day, but like, what are the end outcomes that we need this technology to be doing for us? And, you know, these challenges have been around for quite a long time, but, you know, the pandemic really highlighted that racial health disparities are something that are very pervasive in a lot of communities. We know that technology is not the sole solution to reducing, you know, institutional and systemic barriers that produce racial health disparities, but we know that we can identify and better coordinate around how we can address those health disparities using technology, and hopefully streamline and give folks better access to services. So really engaging on that point too. I'm going to breeze through some of these because this is kind of circling back on things that a lot of folks have already heard, but of course, we wanted to develop a strategy that was inclusive, making sure that we brought in a lot of different sectors to talk about this stuff. It's not just the clinical side, it's patient advocates, it's the social care side, it's the quality, looking across not just clinical quality, but quality for kind of all types of services that produce whole person health. We wanted to have clear oversight, so the HIT Commission was really pivotal with having a steering group that guided the process. We wanted to make sure that because MyHIN has been a partner that we've invested in for quite some time, that we were aligning around what they were hearing from their stakeholders about technologies that were needed, aligned with what key priorities are from the state side as well. Maximizing existing health IT investments, like I've been talking about, and then validating, which, I mean, one could argue that the validation process never ends, because as we start to implement, we're going to want to make sure that what we thought was a solid principle, once we start implementing, is that principle still applicable in the way that we worded it? We might need to tweak and modify once we find out what challenges are or what barriers exist once we start to implement. So always staying flexible. I think folks won't be surprised to see that we had a lot of partners and the oversight of the HIT Commission. Federal HHS was pivotal in the beginning to kind of getting us some initial feedback from federal agencies. The Cedar Bridge Group was used to engage a lot of folks across a lot of different sectors, and you know, we of course coordinated with our state government stakeholders like the Office of the Governor and other state agencies. We engaged quite a lot of people in this effort. Over 500 individual stakeholders were engaged from over 300 Michigan organizations, just accounting for those Michigan-based organizations. We did virtual forums throughout the process, and we had over 250 people registered. We did over 50 key informant one-on-one interviews with folks like COOs, CIOs, executive directors of major kind of thought leaders within the health IT space, ranging from folks who represent health systems, community action agencies, payers. We utilized a lot of different mechanisms to engage with folks. Like, we didn't just do forums, or we didn't just, you know, have conversations. We also kind of got that asynchronous feedback, because we know that we were engaging with people over a pandemic. So we had to be sensitive to the fact that when we wanted feedback from the front line, from providers, you know, they're busy taking care of folks. So having asynchronous ways to engage with them, like through surveys, was really, really critical. And we facilitated a lot of great discussions, which we're going to continue to be doing. It's not like the engagement for this is going to end, because we want to have continuous improvement, and we don't want to get to the point where we're 10 years out needing to update the state's health IT strategy again. So for this section, to actually go through the initiatives, I think I'm going to switch my screen. While I'm doing that, Lindsay, have any questions come up in the chat?
Sorry, gotta mess with the mute. I have not seen any yet.
Okay. Can you see the PDF that I have up now?
I can.
You can?
Correct, I can.
Did you say it? Okay, good. Yeah, so rather than going through slides that really kind of give high level just bullet points, I'd like to actually go through the roadmap itself and the individual initiatives, just to kind of describe what we're talking about. If this is the first time that folks are seeing this roadmap document, the draft that we have posted on the HIT Commission's website is close enough to the final draft. We added one more objective to the adopted version. It was related to a initiative that Commissioner Vandermeer and Commissioner Beauchamp asked for with innovation resources to use health IT for business development. So I'll include that. But if you do want to access this document yourself, the draft version is available on the HIT Commission webpage. And that change that I mentioned is the only one. So This first initiative, when Cedar Bridge originally developed the kind of layered recommendations that kind of underpinned this comprehensive report, which the department produced, this first one is really foundational, and the first one that they listed in their report, foundational to the efforts of us to actually implement a health IT roadmap. So we need champions to advocate for the resources that we need to implement this, and we also need leaders to help continue being those thought partners and staying engaged and connected to, as we implement, giving us continual feedback. And those leaders just aren't just restricted to those that are on the commission. We really want this to be a open and adaptable process where, you know, we have potentially advisory groups that can keep us informed on how implementation is going, if we're staying aligned. So folks on the line today might even be interested in kind of staying plugged into this work and providing us that continual feedback. So it's really an open invitation that we haven't really come up with the structures formally for how that will work. But of course, the engagement for this will certainly remain an open process through the commission. So I've talked about metrics and other presentations, and in full transparency, you know, the metrics that the commission has been evaluating over the last couple of years has related to message volume that has traveled or worked its way through the Michigan Health Information Network. And while message volume is great, I think that there's some other metrics that would be great to consider, like the quality and conformance around those messages that are being produced, onboarding and how much market penetration we have with folks who are able to and can adopt health IT. You know, ultimately, we would love all providers in the state to be connected to health IT, an EHR system, connected to, you know, kind of basic health information exchange feeds. So metrics for how we can show those types of kind of incremental improvements, definitely more than open to hearing about what those metrics could look like as the commission starts to think through that. Because, you know, the commission needs to have the visibility to know how quality HIE is, what the ROI is, and what's needed for folks to buy in more to the system that makes data more interoperable. So the metrics is something that's really underpinning and important to this effort. You know, we'd love to be able to produce reports for, you know, executive leaders within state government, within organizations that are key funders to HIE, and also to the legislature, because the commission is tasked with producing annual reports to the legislature. And, you know, as we build out capabilities for more connected public health systems, for more fluid data, whether that's through CCDs or amplified ADT messages, you know, it's going to take funding to do those things. So the better that we can portray the value add of HIE, I think that, you know, the better chance we have of potentially even the legislature funding some of these improvements too. You know, also thinking, I'm skipping to this next initiative here, thinking about HIE health IT governance in terms of the commission. You know, it's long been acknowledged that more representation is needed on the commission. And, you know, it really could be an endless list of what those, you know, other representatives are who are not currently on the commission. You know, certainly the community services side of the house, since we're thinking about social care, what kind of representative from that world would be best to represent the interests of that sector? We know that behavioral health is not explicitly represented on the commission. The expertise that is called out for commissioners, one of those expertises is in behavioral health, but it might be prudent to have a dedicated seat for behavioral health on the commission. There's no dedicated seat for Medicaid health plans, local health departments, any kind of like nursing affiliation. And I think we're willing to think creatively about what some of these other seats and sectors could look like, because we know that more voices, more comprehensive sets of voices need to be on the commission. So it's going to be part of a effort to think through the actual enabling statute for the commission, thinking about the representation. It's going to require a legislative change. If thinking about that is something that interests you as a partner, more than willing to hear those ideas for what voices might be missing on the commission. And additionally, charging the commission with kind of being more of a active partner in letting the public know and even partners know about what's going on in the space of health IT is something that's ultimately going to support the rollout of the roadmap. So what that education could look like, what those partnerships could look like, about who could help the commission in that education, what the mechanisms could be to get that education out there, whether that's through webinars, memos, really the opportunities for education in this space are really wide, and any innovative ideas that folks on this call might even have, definitely welcome. But there's a lot of important topics that I don't think that the public really even has a basic understanding of, that they would benefit from knowing about, how health IT and personal EHI is shared, security and consent processes related to that, potentially opt-out processes, if that's something that the commission wants to prioritize, consumer access to their own health data, and kind of health data literacy. Those are all topics that, come to mind for me. But of course, I bring these things up as like an open invitation for, there's a lot of expertise within the HIMSS family. So of course, we're open to hearing about more topics that might be beneficial for the commission to educate on. I want to pause. Lindsay, are there any questions about that first initiative? I'm picking on Lindsay. I'm sorry. I could probably pick on Lee too.
I don't see any in the chat. Does anyone want to raise their hand and ask a question at this point?
Okay, not hearing anyone or seeing anyone. What was that?
Nope, I was just going to say the same thing. I don't see any hands going up.
Okay. So the second initiative is certainly one that has a lot of details and a lot of ways to implement. So the concept of health data utility is one that I think has emerged from the pandemic. It is really related to supporting our public health preparedness, and also the many systems that support, public health surveillance and whatnot. So health data utility really makes the system interoperability and the mechanisms for evaluating population health as a whole kind of more coherent and comprehensive across state HIE infrastructure. The commission really emphasized that population health. Of course, the backdrop of developing this roadmap was during a, once in a century pandemic. So, of course, there was kind of a lot of anecdotes personally from commissioners on that. But I think that having better supported public health systems, having the ability to evaluate population health more comprehensively is something that the commission is really interested in seeing how the state can support. And when I say the state, it's not the state with a capital S, it's the state and its partners. So partners across the state, how we collectively can better support public health. So like I said, there's a lot of different ways that we could implement health data utility within the state of Michigan. There's a lot of different degrees to which health data utility could be supported. Some of the objectives that, could play into that and, are listed here in the roadmap are, of course, supporting any type of kind of data hub interoperability with enterprise data services that could be better connected to external partners and systems. So some of the priority systems that the state has outlined in this fiscal year and the previous is, it's MyCal service for serving folks with complex behavioral health needs. The state has gotten CDC dollars for public health system modernization. We're in the process of transitioning to a new child welfare system, so ways to support even like a health passport within the CCWIS system, closed loop referral. And I know that closed loop referral means a lot of things to a lot of different people. And it's funny that, this is something that was prioritized by the commission because no one state has fully figured out closed loop referral. So it's, going to be a continual process of learning for us to determine what's the best route for closed loop referral for our state. But it's certainly something that the commission wants to be a partner in helping to figure out because they identify the value in having a closed loop referral system. And we also benefit on the state side from having one master person index, so ways that we can leverage that. So some concepts that, of course, we support within our infrastructure for IT within the state, thinking about building out things with modularity, keeping interoperability in mind, leveraging existing investments. I feel like I've said leverage existing investments now at least 5 times, so that's not been conveyed as a priority. I'll probably say it a couple more times. And alignment with industry standards, that's really a broad call within health IT, given that, we're not still just thinking about clinical data standards, we're also now thinking about social care data standards and all the different permutations for that. So the commission wants to be a more active partner in advocating for and promoting widely these kind of core services that have always benefited the state well, like the ADT system, the attribution system, just because there's so many partners that have already shown that there's collective benefit in those systems, and the commission wants to continue being a partner with promoting those. Activity 2A2 is really kind of as closely associated still with that previous, so those core services those core HIE services that have always served the state well, making sure that funders commit to continuing to leverage those core capabilities wherever possible, not redoing the wheel, focusing on the continuation of common shared services. The more that we can leverage and build out existing services, the more that we can enhance and find collective ways to continue improving those services. And the commission acknowledges that of course MyHIN has a lot of efforts to convene folks to continually discuss about new use cases, whether that's the use case factory or different ways to improve data within those use cases, like conformance work groups. But I think at a very high level, having greater advocacy and kind of awareness opportunities, either through work groups or through, really just kind of publicly visible discussions about data accuracy and quality, is something that they would like to be a partner in. And this, Blue Cross Blue Shield has really done a great job with thinking about conformance and how they incentivize that within their provider network, and thinking about how other organizations, such as the state, could leverage some of those best practices, is something that I think would give us greater outcomes and kind of more collective impact with how we can improve HIE data. And promoting CCDs, of course, is something that makes clinical data more fluid and able to transform more easily. So the dedication to that effort is one that the commission wanted to highlight as well. This creating an innovation ecosystem for health IT leveraging HIE is one that was explicitly asked for by 2 commissioners. Still trying to discover what implementing that type of infrastructure would look like, but certainly wanted to call it out in the roadmap, just give it that there's an opportunity for Michigan to be a leader in this space, as Commissioner Beauchamp and Commissioner Vandermeer had described in the recent commission meeting. So thinking innovatively and openly about this activity is something that, we would definitely love more partnership on. So we know that the federal government has thought about patient-mediated exchange through different policies and regulations for some time. And so individual privacy and security is something that the commission wanted highlighted in the roadmap. So whether that's through convening work groups to talk about and bring visibility to those topics. So how can we as a state do better with consumer mediated exchange? Are our current efforts enough? Are consumers wanting to see more? Do they know enough to really utilize these capabilities to the fullest? Are all things that the commission would like to engage the public on. And I think having a set of guiding principles, give it that there's probably these already existing, having the visibility of those principles could really support those efforts. Using those as an education tool, especially in terms of folks having the awareness of if it is of interest to them to know about how opt-out works, is probably something that would be beneficial on this topic as well. I know that there's been some commissioners that have been approached to kind of learn more about the opt-out process and how there may be some current barriers and challenges with how opt-out works right now. So kind of figuring out how all of this plays into consent, privacy, security for the commission to be more of an advocate on. And in terms of standards development, we know that the commission can't just jump into this space overnight and kind of be a advisory body on its own. We know that everyone is thinking about standards in a lot of different capacities. So this is not to say that the commission is stepping into this space and wants to have the end-all be-all conversations about standards. But given that a lot of organizations are having these conversations about standards concurrently, it would be great if we can come to open state spaces to talk about these topics together, to learn and leverage best practices from each other on how we leverage standards like US CDI or even social care ICD-10 standards from the Gravity Project. So this is more of a call for collaborative work groups, not definitive work groups in terms of standards development. Standards development is also really key to Initiative 6, which gets at social care data sharing. The commission is more so interested in providing the spaces for folks that come together to talk about these topics, rather than kind of being a definitive source that decides things for the whole. Of course, the state has room to kind of develop standards on our own for, such things as like how we share race and ethnicity data, how we share sexual orientation, gender identity, expression data, SOGI data. So all of these conversations coming together at a common meeting point is one that the commission has expressed interest in. So as you can see, health data utility really encompasses a lot. I already touched on consent management, which to a certain degree ties into the privacy and security aspects. But in order to have a health data utility model to leverage data for analytics and for kind of collective learning, this consent conversation is one that is really paramount, because we can't leverage data for broader uses in many cases and can't just pull it for analytics, can't share it across systems kind of indiscriminately without that consent mechanism being in place. So we know that MyHIN is in the process of developing its e-consent platform. So that's a great stride in the right direction in terms of moving towards a statewide consent management system. But we know that, one use case for sharing behavioral health data is not enough in terms of, kind of closing out this consent management system activity. So a lot more work and a lot more development in how we build out statewide consent management, but it's one that's really foundational. There were a couple use cases that folks mentioned as being particularly critical that we build out within HIE. Some of those relate to how we share medication information, advanced directives, and how we, as a state, work through identity management. Of course, a lot of different ways to approach those three use cases, but we did want to explicitly list those as ones that folks were calling for and wanted to see built within our HIE infrastructure. Kind of closing out this HDU initiative, like I had mentioned, there's a lot of interest in connecting all points of care in the care ecosystem, still lots of providers to onboard, but some populations, special populations that folks wanted to see, and when I say folks, stakeholders that we engage with for the roadmap, wanted to see kind of HIT kind of reach out to and have more effect on the care for. Services that affect children, justice-involved individuals, and behavioral health patients. It was identified throughout our engagement that those three populations face particularly disparate outcomes. So thinking about how we can use health IT for care coordination, care service management across the continuum of care. So really thinking about additional use cases, really, when we get to implementing about how can we best affect care for these three populations. I think that there's still a lot of room for feedback for how we can do that, just given that these three populations were very explicitly called out in our engagement. I talked a lot about this initiative, so I want to at least give an overview for the other initiatives, because while Initiative 2 is kind of the biggest, I think that these other three, the importance of them can't be minimized. So like I had mentioned, you can't leverage health IT much if you can't even access the internet. And we know that there are a lot of funding opportunities for building out broadband, even opportunities in the next year. So at the Office of the Governor level, there is the Michigan High-Speed Internet Office, which is currently convened by Connected Michigan. MDHHS is a partner in work groups that the Michigan High-Speed Internet Office is convening. And over the next year, there's interest in prioritizing where broadband investment should be, what device connections are needed to get folks access to the internet. And, especially in terms of healthcare delivery, it's really crucial to think about how devices can support, things like telemedicine, remote monitoring. So the commission has really expressed a lot of interest in participating and advising the department on how these broadband investments can benefit healthcare. So this is one that's very actively being worked on, but of course, always looking for partners for how we can learn to affect change better in the broadband space. I think crucial to kind of connecting all points in care, acknowledging that there is still space for onboarding and technical assistance. So some of the ways that have already been conceptualized, but of course we're open to hearing additional thoughts on how we can effectively do this, is convening groups like an EHR work group to ensure that providers have technical and system planning resources in dealing with all the different EHRs that they interact with. MDHHS being a facilitator and leader in kind of getting resources to folks to onboard and have TA, and also exploring how regional efforts could be coordinated to support folks locally we know that a lot of kind of nuances to inaccessible technology or not having the funding to implement these technologies may have regional aspects. So how can we perhaps have regional coordination efforts or partners to help us address this onboarding and TA need? We heard loud and clear that telemedicine is something that benefited a lot of providers during the pandemic. So in thinking about onboarding and TA, folks still need assistance with how to optimize their use of telemedicine. So within this initiative, thinking about how we collectively can support each other and our providers in implementing really great and accessible telemedicine services. I am going to get through these last two initiatives somewhat quickly because I rambled a little bit on that second initiative and I still want to open it up for any questions. So I've spoken a lot already about the need to support our public health systems infrastructure. And it really goes without saying that the funding needs and the needs to update systems has really been highlighted throughout the pandemic as a very prominent need. Some of the ways that stakeholders said that these public health data systems can improve is having more timely and accurate data, enabling bi-directional data flow, and also having statewide registries for chronic disease that can enable folks to better care for and have awareness around the disease burden of particular chronic conditions. The Commission has dedicated itself to prioritizing the development and maintenance of use cases that can support these different activities, and rolled into the need for more accurate and timely data. We know that, as I've highlighted already, the need for data quality within these systems is really pertinent. If we want to have evidence-based intervention type systems, you need to have quality data to fully describe and accurately describe what's going on with the populations that you're looking to affect. So the Commission, of course, wants to be a thought partner in this and pursue any type of funding and advocacy for the data quality and the utilization of public health use cases that benefit to this end. But the need to rally around particular work groups or committees to think about the data quality and conformance opportunities, both within the public health space and within the general HIE space, is one that I think we could really benefit from a lot of partnership and continued collaboration on. We're not going to solve the data quality challenges in silo. So I know that, like I said, there's a lot of thought leaders here on this call today. If that's an area that interests you and you would like to discuss more, I think that the Commission would benefit from hearing your perspectives and ideas. So lastly, I saved SDOH for last. This last initiative is really thinking about social care data, obviously something that a lot of organizations are thinking about right now. We know that the Commission on its own can't kind of solve the SDOH data challenges that we're all kind of collectively facing, but using its abilities to convene statewide work groups and give visibility to a lot of the conversations that we're all concurrently having, I think would be great for not only convening, but also aligning folks. It's funny because in the space of SDOH, the Policy and Planning and Operational Support Administration, we convene a lot of SDOH conversations, and it's funny because a lot of the folks a lot of folks across organizations are having similar conversations or the same conversations across their own organizations. And when we come together to talk collaboratively, it seems we're all talking about these things internally. And, through the department's SDOH strategy efforts, we're kind of taking some of the layers off that and uncovering, where some of that alignment is. But, to a certain degree, some SDOH is occurring at a different pace for all organizations. And there's so much more opportunity to align. I'm glad that in our administration, led by Nina Sassy, who's on the call, I'm glad that SDOH is something that the department's focusing on, because it's something that's long overdue. It's of course a very large conversation. So the commission's role, I think, is being a thought partner, bringing folks together to talk about things like data standards, bridging some of these conversations that folks may be having in silo about social care data, and kind of thinking about how we can, at a comprehensive level, look at population health analysis. Of course, all very large calls and all very kind of ominous things to think about, but I think if we do that collectively over the course of the next 5 years, and if we commit to working with each other on that, I think that there's a lot of great opportunity. So that really kind of sums up the 6th initiative. I left only 5 minutes for any kind of questions or comments, but Lee and Lindsay, I will pass it back to you because I think I have talked enough.
Thank you so much, TJ. Wonderful presentation. It's really good to see the progress that Michigan is making and looking forward to making. So wonderful presentation. I do see, there's no chat, but I do see a hand raised up. Mamanta, I'm going to go ahead and you should be able to take yourself off mute, but if you can't, I will.
Hi, can you hear me? This is Mamata from Client Office Services.
Yeah, we can hear you.
Hi. So yeah, thank you for that presentation and giving the opportunity to join this meeting here. I did hear about a lot of initiatives, multiple initiatives to improve the data quality shared within HIEs, and also the future initiation with the open invitation of, to promote the shared visions. We actually are focusing on a health IT innovations, and as part of it, we are working on the solutions and have the prototypes that are in line with HIT and the ONC roadmaps. So our solution basically have, the purpose and the goals meeting and leveraging the existing and collaborating with multiple sectors of the stakeholders here. So we have a prototype and the white papers to share in order to solve some of the initiatives here, and would like to share and have some support from the HIEs and the regional HIEs to take this to the healthcare stakeholders in terms of collaboration and the partnership, like providers and payers as well, with the other HIDs like Cedar Bridge Group that you were mentioning, so we can leverage our solutions and the use cases that we have in terms of addressing these initiatives. So in terms of that, how would you able to help us out or support us in taking this kind of innovations to the state?
Yeah, thanks for that comment. I think any kind of white papers or resources that can be shared with the commission, we certainly welcome. We can provide my email in the chat, or Lindsay, if there's a better way to share my email. Certainly willing to share any kind of learning or white papers with the commission for them to consider in this effort.
Okay, that sounds really great. Thank you so much. I'll just get that email out from here, and I will email you shortly after this meeting, so you have our information. Great, thank you so much.
Yeah, thank you.
All right, I don't see anything in the chat. I don't see any other hands raised. Did anyone want to just come off of mute and ask any questions? We have about 1 minute. All right, I did add TJ's email address in the chat as well. If anyone wants to reach out to him via email, I will go ahead and think we can wrap it up. TJ, again, thank you so much for this presentation. And I also want to thank our sponsors again, Connection, SafePass, LK, our executive sponsors, Blue Cross Blue Shield of Michigan, MyHIN, Pure Storage, MSMS, and Seal Shield. Thank you so much again, TJ. Everyone have a wonderful day.
Thank you, everyone.